What in God's name? Family's not a newborn, but a man well in his 80s on his way to the grave. He's done? Old age. How did that old? Looks just like my ex-husband. My name's Benjamin Button. How old are you? 7, but I look a lot older.
Hi. I think all of you have seen this very interesting movie, The Curious Case of Benjamin Button. This is a nice story where a child is born who appears like almost like a very elderly man who is at the verge of death. And the story goes on how he evolves from a very old dead man to a baby over a period of time, and how the life goes through that. So there is a lot of things. When you look into life, the curious case of Benjamin Button gives us a lot of things to think about what we look into it. We know science as we know how we try to argue it out. This science or the occurrence of this science of knowledge is called as epistemology or theory of knowledge. Different schools of philosophies, different schools of learning, different schools of thoughts have used different ways of discussions of these knowledges, and each of these schools believe what type of evidences can be utilized to tell that to prove something is a knowledge or not a knowledge. I have just put some of the names here which are based upon Indian schools of knowledge or Pramana Shastra or the theory of knowledge or the epistemology which is spoken in the Western literatures. Different schools accepted different numbers of Pramanas, means not that everyone believed everything. Each one had their own limitations, how they looked into the knowledge, and based upon that knowledge, they accepted that level of proofing, they accepted that what was acceptable knowledge. Today, in this talk, I'm going to talk about medical management of Parkinson's disease, an epistemological journey. My goal in today's talk is just not telling that how do we manage, because for this august audience, I clearly know that all of you know much more than me and know that what is the current standards of therapies. We all know Levodopa is the current gold standard, but what does is there for us to learn in this today's talk? How is the medical management of Parkinson's disease is going to appear different? What we are going to look into it. I have taken the example of the curious case of Benjamin Button and an epistemological approach. I'm not going to talk about why I'm taking certain things over other, but I want to see how this evolution has happened, and this itself should give us the concept of the abandoned child, abandoned child with the Pramanam Shastra of Pratyaksha. We'll go through that each one of them and how I have developed it from the old treatment periods to the miracle years, the paradox age, the cumulative knowing, the intuitions, and the future child. This is how my talk is organized here for the management of Parkinson's disease and how it matters to us. The concepts of epistemology are just given at introduction of the slide just to give an aspect how that rationality is of discussion is going on in my talk. If you see the whole movie, that starts with this child. If you see that, it's a newborn child who looks very old and is almost at the verge of death. The point sometimes in life for most of us is all the story starts with the concept of the abandoned child. It may be abandonment for something, but this is the first time when the child is seen by someone. That is, in our medical science, it's about recognition of a disorder when we see it for the first time. This was a knowledge which was followed by the followers of Charvakas, which they called as Pratyaksha knowledge, means that knowledge which is only seen is believed, the epistemology of inevitability. If you look into the concepts of Parkinson's disease, the concept called as Parkinson's or probably something like that was well explained in the Indian literature in Charaka Samhita, which was called as a Kampavata or tremors, or Shirakampa or head tremors, Sheshta Pranas or akinesia, or Stabda Gata Ratava, rigidity, or Chitasana, dementia, and Buddhi Prava. These are the different terminologies were utilized in Charaka Samhita, which was written around 2500 BC. But probably a little bit well description had came around 1400 AD when the book of Ayurvedic book called as Basavarajyam, where elaboration of tremors of hands, feet, difficulty in body movements, disturbed sleep, and dementia as symptoms of Kampavata were discussed. Yes, they were using mucinapurines and ecosamas. We'll not talk about that because the whole story of these Kampavata evolves for us as a modern sciences when James Parkinson's discussed in his essay called an essay of shaking pulse in 1817. This, the essay of the shaking pulse in 1817 was well attributed by his name, called as Parkinson's, with advent of Western colonizations, advent of knowledge being spread across different continents, and all of us, we know this as the Parkinson's disease. So with that accepting, we knew when the disease was accepted, we very well knew that this was a disorder, probably in 1817. It was only seen as an inevitable disorder. You recognized it, but yet the inevitability was towards death. A child which was seen was almost at the verge of death. Now, coming to the next section, the chapter 2 is on the old treatment periods. This is where the concept of anumana will come. This is from the Indian Nyaya philosophies, where inference, you are reasoning towards what you cannot see. You try to do something to justice it out. Whatever you have, you try it out. If you see in the early 19th centuries, various types of therapies have been utilized for management of Parkinson's disease in modern sciences. It includes the vibratory chair of Sharkar. They have used every other compound which was used during that period for management of Parkinson's disease, including compounds of mercury, belladonna, ergot of rye, or the clap mixture which had contained some type of anticholinergic products. So this was a time you try to do what was feasible and try to get something which was sometimes some effects were there, but most of the time you ended up being not having best benefits. However, we are not far away from that initial what you call it as failures. We started to look into the field much better. When things started to grow for Benjamin, you could notice that life started to go, started to accept the situation the way it was, and we started to look forward into it. This is where the miracle years came in. Miracle years is a concept where I have taken from the concept of Mimamsas, that is where Upamana and Arthapati is the primary basis, two of the couple of philosophical approaches which have been utilized, where analogy and postulation becomes the point of evidence to manage something. The answer sometimes, many times, arrives from a wrong field entirely. And this was where we could notice that the answers for Parkinson disease also started to come like that. This was the era in early 20th century when a lot of treatments were not available. People were searching for that. And this is the concept where in 1939, Siddiqui et al., an Indian pharmacologist, discovered the effect of Rauwolfia serpentina on heart rate. At that point of time, you should remember that there was no specific therapies for management of hypertension. And the SIBA labs isolated the alkaloid reserpine from the Rauwolfia. And this was the first blood pressure lowering medications which was available for management of Parkinson's disease. Once this product came into the picture, they started to utilize it for management of hypertension, but they also started to notice that it used to calm down a people. So hence, at that point of time, people started to use this reserpine compound in various asylums to calm down aggressive subjects there. They started to notice that it had a good sedative and calming effect. However, soon they started to discover that many of these subjects who were on reserpine started to develop features of Parkinson's. And hence, they could attribute that there was something which what reserpine was doing can cause Parkinson-like symptoms. And they were able to postulate around the early 1940s and 50s that reserpine caused depletion of serotonin. And that led to a lot of works during that tenure in 1940s and 50s. And the famous work or the famous rabbits of Arvid Carlson here, who proved that dopamine depletion caused reserpine-induced Parkinsonism and that levodopa could reverse it. This was his great classical paper which was published in 1957, which clearly shows reserpine-induced Parkinsonism in two rabbits who were able to completely be reversed with giving levodopa. There have been multiple other people who have been worked around that. Specific mention has to be done for Arvid Carlson, Ol Hornikiewicz, George Corgius, and Melvin Yare for their contributions for the early evolution of therapy. We should remember that even that later on, Arvid Carlson goes on to receive Nobel Prize in Physiology for discussion about these molecules. So you could notice that how a compound which was discovered for potential management of hypertension led to management of psychiatry patients, which led to Parkinsonism, and serendipity showed that how that chemical can be reversed to leading to that. And this finally led out to this great classical iconic video, what you can see here. This is a great iconic historical video from the archives of the movement disorders. You can see a person who is there, who is severely akinetic, rigid, who is bent camptocormic before the levodopa. And there, the right side video, which shows that after taking the levodopa, the same person is active, moving around. And what I could see from here, there was no going back. Parkinson disease, a child which was born as a possible inevitable death, started to have a life, a better quality of life, what you can notice down. This is how a child evolved to becoming more middle-aged man, what you can notice from the points of a elderly dead person. Then we started to go further. It was not like something which was not feasible. This is where we started to look into the age of the paradox age, where we started to look into the concept of rationalism, which has been predominantly been propagated by Descartes. It was the concept that the first principles is reasoning. If you can reason it out, you can get better answers out of that. So once we knew, people started to play around with different aspects of management of disorders. The first and foremost were the surgical therapies. You can notice that the great works which were done, which was in the form of lesioning surgeries, or later on with the development of DBS in the late 1980s or early 1990s. We also understood with that time that the levodopa is depleted in the brain and how the levodopa acts on the metabolism, how the metabolism of the dopamine occurs, where it is released, which chemicals are involved in its metabolism, how it has to be transported in or outside of that. This led to development of various molecules, the gold standard being levodopa, followed by dopamine decarboxylase inhibitors, dopamine agonists, MAO-B inhibitors, COMT inhibitors, and various other medications. I'm not going to go in detail about each one of these molecules, but I'm going to give you a bird's eye view of something what you should be knowing. Levodopa is the current gold standard. Most of the time you can see on my left side, the critical reading or high impact articles are shown there for people who are interested to read about these drugs or molecules. But you should remember that in a puristic form, only 1% of the levodopa reaches the brain. Hence, it is combined with dopamine decarboxylase inhibitors. So, carbidopa or benzerazide are the commonest molecules which we use it. And it has a dose response is powerful, but many times it's not linear. But motor complications are disease and stage dependent. Many people are worried about that levodopa will cause dyskinesia, levodopa will cause hallucinations, levodopa will cause this, levodopa will cause that. But this is primarily disease and stage dependent. Common side effects are nausea and up to 30%. And with this one of the nice articles where we looked into multiple people, about 3,000 people across the globe to see what are the patterns. What you can see that the initial escalation of levodopa happens during the first 7 to 8 or around 8 years of life. After that, most of the time it remains stable because the issues are related to other forms of the symptoms. The right side panels show for the type of molecules what are the type of formulations which are available. Levodopa is currently available in tablets, extended release formulations, inhalers, subcutaneous infusions, transdermal infusions, and GI infusions are currently available for utilization of levodopa. Once the levodopa was found, then the clear concept came in that dopamine agonist could be second molecule which can directly stimulate dopamine receptors. So it gave a concept for levodopa sparing strategy. It had lower risk for early motor complications as compared to levodopa, and it also assumed that there is a continuous dopamine stimulation hypothesis. As compared to levodopa, these molecules had longer T-half, so we assumed that it has a better stimulation or continuous stimulation capability for the dopamine stimulation. However, many of these dopamine agonists have significant neuropsychiatric side effects in the form of hallucinations, impulse control disorders, excessive daytime sleepiness, peripheral edema. Their adjunct role in advanced disease is also considered probably in reduction in off times. They have evolved from regular tablets to transdermal and extended release molecules, infusion pumps and pens, for example, for apomorphine, which is currently available, or rotigotine, which is available as patches. These are one of the commonly used next line of medications along with levodopa. MAO inhibitor has been catch of the eye since the early concept of treatment, but they have been seen the primary concept of utilization of MAO inhibitor is it targets the dopamine breakdown, hence not primarily the dopamine production. So utilization of dopamine in the body can be for longer time. It has a goal in early disease utility, leading to delayed levodopa utilization, motor fluctuations, reductions in advanced PDs. But common MAO-B inhibitor which are utilized are salicylic, rasagiline, and safinamide. Special mention for safinamide is that the contribution of India, especially Professor Rupam, in the great safinamide study, which you can see down there on the left-hand panel, has been primary contributions as one of the primary data for the approval of safinamide for management of Parkinson disease. But we should also remember that prasagiline and salicyline, all these things have severe serotogenic reactions like the cheese reactions causing the hypertensive crisis, basically from the thiramine. But what you can see that rasagiline does not produce the amphetamine metabolites unlike salicyline, reducing the cardiovascular and sympathomimetic concerns. Next line of molecule is specifically the anti-glutamatergic, that is amantadine. The NMAD receptor blockade is classically utilized as the primary, the anti-dyskinetic drug. It has a modest symptomatic improvement And the primary utilized molecule is amantadine. Others includes memantine, dextromethorphan, budipine, rimacimide, and riluzole. Side effects are very sensitive in elderly people where cognitive and peripheral issues can be noticed in the form of confusion, hallucinations, edema, insomnia, and visual burning. There's a nice booklet on amantadine in Parkinson disease by Professor Vinay Goyal. If you people are able to get it on Amazon, please take it and read it. There is nice anecdotes, nice discussion about amantadine has been written with all the evidences on amantadine for management of Parkinson's disease. Anticholinergics probably is one of the oldest molecules, what you can remember from various backgrounds it has been used. It restores the dopamine and acetylcholine imbalance probably, which is happening in patients with Parkinson's disease due to deficiency of dopamine. But what we can see it as a predominant benefit in tremor focused role. It has a modest overall efficacy for all symptoms put together. However, its central cognitive side effects limits its use. Commonly utilized is trihexyphenidae. Other molecules includes benzotropine, ethopropazine, procyclidine, diphenhydramine, and bronopin. Currently, for day-to-day molecules, it's in the tablet formulation, which is available for management of Parkinson's disease. COMT inhibitors, similar to MAO-B inhibitors, work in reduction in the dopamine metabolism speed. So it works as purely adjunct therapy. So based upon that, it reduces the off time in advanced Parkinson's disease. Currently, entacapone is the primarily available molecule across the globe, and tolacapone is almost out of the market, primarily due to risk of hepatotoxicity. Currently, a new COMT inhibitor, once a day daily utilization have come, that is opicapone, and it's a long-acting COMT inhibitor. Current entacapone used to be given with every dosage of levodopa. Opicapone may not be required to be given like that. In addition to these medical line of management, we also have deep brain stimulation surgeries. This surgical therapies, the lesioning surgeries, either based upon direct classical lesioning or MR guided first lesioning or radiation based lesioning have their own benefits and their own limitations. But the best surgical options what we have for management is the deep brain stimulation, which is based upon circuit theory about connections between different circuits of the basal ganglia and not primarily related to dopamine replacement. It is very good for best for motor fluctuations and dyskinesias. Levodopa responsiveness predicts the outcome. But do remember medication reduction and improvement in quality of life happens, but it's not a cure for management of Parkinson's disease. What I spoke till now all about in relation to the motor aspect. When the whole concept of rationalization of treatment started to happen, the primary paradigm of motor, everything tremor, slowness was being looked into it. And then we just realized that Parkinson's disease was just not a motor disease. It had a completely different paradigm, the non-motor system, that is the root system. The shoot system was something which everyone is able to see and recognize and acknowledge easily. But there is a whole root system which include dysautonomic symptoms, sleep disorders, behavioral or neuropsychiatric issues, cognitive disorders, and sensory symptoms, to name a few, which have its own complete set of symptoms which many times predate the early on clinical diagnosis of Parkinson's disease. And as time goes by, these symptoms becomes the major burden in the management. Recognizing the motor symptoms, recognizing the non-motor symptoms, and addressing them the apt way remains the primary critical point in management of Parkinson's disease. I'm not going to go in detail about each one of these various molecules, but for the audience here, what I can tell is in a simplistic way, when you see a clinically confirmed Parkinson's disease, if it is limiting quality of life, it is not limiting quality of life, reassurance exercises, MAO-B inhibitor possibly could be good enough. However, If it is limiting quality of life based upon the age at onset, you can decide what options are required. People with mild or younger age, probably dopamine agonist and anticholinergics, if tremor dominant, can be considered and should help in improvement of quality of life. However, if they don't have benefit, didn't tolerate, don't wait. And definitely in moderate symptoms and people like elderly people, levodopa should be your first choice of treatment without any question. Because improvement in quality of life is much faster, better, and risk of side effects are much lesser as compared to the other forms of therapies. Usually, it has a good improvement in quality of life, but down the time, people will develop motor complications. You manage motor complications with various combinations with COMT inhibitors or glutamatergic medications or dopamine pumps, dopamine rescue injections. In spite of that, if there improvement does not happen, then probably you may consider apomorphine pumps or DBS as a part of continuous dopamine stimulation therapy as an option. However, everything at the end of the day has to come into more into in the later phases will end up a palliative care. If you are looking at management of Parkinson disease, this one slide should be able to talk about what I was talking in this rationalization phase of the management of Parkinson disease. However, our story is not yet finished. If that could have been the best for us, right? We know that the curious case of Benjamin, his life comes. This is the phase where he meets his friend at the same age, at the same biological age at this phase. He is also young and charming. Now she, who was a young girl, small girl, has grown up to be a charming lady at that point of time. So we are at that crux of the life what all of us are going to. This is where we are going through a cumulative knowing. We are trying to understand a lot of things about we ourselves and we ourselves with Parkinson disease. Probably the shabd, the way of discussion is the best thing. It's a cumulative collective knowing. Science as a relay across decades means we try to understand various aspects about that. What we have understood till now. What we can see that if you see the x-axis as a timeline, y-axis as possible neuronal loss and symptom burden, and the orange line in the center indicates the neuronal loss threshold for the motor symptoms when the symptoms occur, and the maroon dotted line in the center shows when the appearance of motor symptoms occurs. If you look that as a possibilities, this is how a simplistic way of how the neuronal loss will be happening over a time with accumulation of the symptom burden. Neuronal loss is happening. If you see in the lower left corner, neuronal loss has started to happen quite early, but the symptoms usually appear when significant number of neurons have lost, significant amount of time has gone into evolution of these symptoms. Then if you have no therapy, the curve keeps on going forward without ending. This is what we saw during our the initial SA palsy or the early 19th century therapies. Now, with the advent of pharmacotherapy, what we are able to do is we are able to improve the quality of life. Someone who has certain symptoms, we break the symptoms down, improve the quality of life. But yes, over a period of time, it starts worsening further. Once we have a limit, because pharmacotherapists had their own limitations, we have now came to a knowledge that combinations of pharmacotherapies and surgical therapies can give a second dip to improve the quality of life much better with medical and surgical therapies. This is where all our treatment paradigms are happening. In the upper right corner, what you can see down based upon this graph. What we are missing is the whole lower left corner, which remains completely unaddressed. We are there, but what can be done here? This is the whole concept, what we are trying to get the cumulative knowledge, what we are understanding and what we are missing it out. We have now understood that Parkinson disease is not one single disease. It has genetic component. You should be born with certain genes or gene risks which can potentially cause Parkinson's. And it should be supported by epigenetics. It may be environmental factors, stress, strain, exposure to pollution, and all those things. Both of them combined risk factors trigger various molecular pathways. Based upon what type of genetic load was there, different molecular pathways are triggered. It can be immune system, mitochondrial function, vesicular transportation. We know that different genes are involved in the different molecular pathways. Not everyone should have similar single pathway, leading to occurrence of Parkinson's disease or Parkinson disease symptom. However, at this phase, we are treating all this Parkinson disease population with similar set of medications and not trying to segregate them. We need to segregate them based upon their molecular pathways and genetics and try to address them to give more personalized medicine. People with immune system pathways require certain type of therapies. People with mitochondrial dysfunctions require different type of therapies. People with protein aggregation issues primarily will require different type of therapies, and people with lipid metabolism disorders will require different types of therapy. This is the concept what we need to understand and evolve down. And this is the phase what we are going through that. So what I can tell is same disease label does not mean the person is having same genetic architecture. We need to have, there are different pathways which are being working, which is causing Parkinson disease. And this is where the concept of biomarker works has come into it. A nice paper by Professor Damija and his group on biomarkers, please read about it, where they have spoken about different types of biomarkers and possible works can be considered in picking up the people who were in the lower left corner in the graph what I told about. Understanding this helps us to understand better biology pathways, better risk prediction tools. It helps in better representation in global research and better clinical trial designs, because we are now can plan trials based upon ancestry aware, what about genetic components we have. That is where a lot of global teams have come together for cohesive work. The global Parkinson genetic work is happening because of that. And India, it is represented through the Parkinson's Research Alliance of India, the PRI, which is working on pan-India works on these neurodegenerative Parkinsonian disorders. We have to work on these things so that we can go and try to have better answers down there. So what we are looking for, based upon those concepts and understanding, we have now come to the concept of what is called as Kash and Prajna. This is based upon the Sufi and Buddhist learnings, where intuition, you have learned so many things. Sometimes you need to have that intuition. Sometimes you get you have your sixth sense to tell us that this should work, that should work. Or you get a dream that when you're thinking something with your full heart, you get that dream that's how to do it. That intuition. So this is a knowledge that arrives before the proof. We are looking into that. This is the phase which all of us are going through, and I'm going to give you some of the trials and drugs. I'm not going to go in detail in each one of them, but for the curiosity of this August audience, I'm going to talk about this, what molecules we are having as of now at the end of, at the beginning of March 2026. The most important medication, the new trial which has been looked where we can try to disease modify is the prasinezumab monoclonal antibody, which is an anti-alpha-synuclein monoclonal antibody. The most important study has been the Pasadena study, which began in 2017. It neutralizes extracellular aggregated alpha-synuclein to slow the spread but toxicity. So targets the proteinopathy targeting. There has been a publication which came out, but the result has been equivocal or mixed. The Padova phase 2b reported not meeting primary endpoint. But Roche stated signals suggesting possible clinical benefit and is advancing into phase 3. So this is how I'm going to give some of these molecules where I'm going to talk something little bit about human. When did the human trial start? I'm not going to talk about trials which are still at phase 1 or phase 2. So when the human trial started, what was the scientific rationale for these molecules, why we thought that they should help in management, what intuitions we had, what are the major, a single or a couple of major clinical papers about these molecules, the current status, and possible future are the primary companies which are working on that. So going forward from prasinezumab is sinapininab. It is also an anti-alpha synuclein monoclonal antibodies. A phase 2 spark ran in early Parkinson disease. However, this was a negative study and it has been completely been de-emphasized now by the primary sponsor. The next molecule is a GLP-1 receptor agonist, that is lexinatide, which is a phase 2 Lexipar published in 2024. It's a GLP-1RA class and it is hypothesized to improve neuronal resilience via metabolic, mitochondrial, inflammatory, and trophic pathways. It is promising but not yet definitive. Phase 2 showed less motor worsening versus placebo, but GI tolerability issues needs to be addressed. Likely, it will go into phase 3 study and we'll be able to see something down the time. Exenatide is another GLP-1 receptor agonist. However, it has ended up as a negative study in a phase 3. Exenatide itself looks unlikely to proceed as a disease-modifying therapy, but GLP-1RA class remains still active for potential looking into addressing this metabolic, mitochondrial, and inflammatory and trophic pathways of Parkinson disease. Next molecule is DNL151 or BIIB122. That is, it's a LAR2 kinase inhibitor. Luma commenced the studies in May 2022. LAR2 hyperactivity is implicated in familial Parkinson disease and may contribute to sporadic PD biology. Inhibiting kinase activity aims to modify the upstream pathogenic pathways. However, the studies are still ongoing. Its unknown efficacies probably may not apply well to the Indian subset of patients, mainly because LAR2 is not very common as compared to the Caucasian or the European or the West Asian populations, what has been noticed of. Near-term future depends upon the Luma readout. Main companies involved are the Biogen and the Denali. Ambroxol is commonly over-the-counter available molecule. It is a GCase chaperone or which acts on the lysosomal pathways. Studies have been published in 2020. The ambitious study protocol, which is now published in 2023, is looking for recruitment listings since February 2025. It boosts glucocerebrosidase activity to improve lysosomal function, reduce pathogenic lipid and alpha-synuclein interplay, especially relevant in GBA-associated PD. It's ongoing study with unknown efficacy, but the previous study published in 2020 was not so active, not so supportive in the outcomes. Another GCase allosteric activator is BIA 286156. It was first patient dosed in August 2023 and it's still an ongoing study and we need to see how this trial will work out. I'm just giving a couple of different molecules, how they are working out and what is the status of that. PR001 is a AAV9 GBA1 gene therapy disease. Its public reporting indicates dosing initiated in 2020 in PROPEL study. It works by delivering functional GBA1 to increase GCS activity, long-term, one-time gene therapy approach to lysosomal. Basically, we're trying to correct the lysosomal pathway here. It is an ongoing early phase study working on GBA mutations. People have also working on various mitochondrial functions. Among them is the urisodeoxycholic acid. It is in phase 2 up study ran in early PD. It has early results have shown equivocal bar early signal as safe and tolerable. Primarily, this is also used with combinations with other platform projects which are happening. In this platform project is the EGS Act PD, that is MAMS, which is they are trying to use telmisartan and tetrazocin along with UDCA, where they are trying to use the repurposed candidates with mechanistic neuroprotection signals. This is a key infrastructure accelerating project, but we need to see probably the arms are going to be activated this year and the coming years to see what will happen. We need to wait and see on these things. There are some active immunotherapies has been utilized, are being tried as against alpha-synuclein as vaccines. They generate patient antibodies that bind pathological but oligomeric alpha-synuclein, hence aiming to reduce the spread of toxicity. Some of these studies have early positive signals, but still unproven. Active immune reported positive interim phase 2 trends, but definitive outcomes are pending. If the signals hold, this could become a leading active alpha-synuclein approach. The key company involved is AC Immune here. Next is the molecule called as uh, uh, NLRP3, which is primarily used to target the neuroinflammation phases. So we see that in Parkinson disease, there's chronic microglial activations, and NLRP3 inflosomal activation is hypothesized to drive neuroinflammation, potentially accelerating synucleinopathy and neurodegeneration. Anything which can stop it or reduce it can help you out. So this is an ongoing study, and currently we are waiting to see what is going to come out of that. Next set of molecules are targeting the tyrosine kinase pathways, the c-Abl inhibition. It's a multiple early human trials have been done. It's implicated in pathways affecting the alpha-synuclein, handling mitochondrial stress and neuronal survival. Inhibition is proposed as neuroprotection. It is mixed to negative so far for older agents. Next generation compounds are still being tested. Future dependence on brain penetration, selective c-Abl inhibitors, and multiple sponsors which we are looking into it. Next is how to rescue the neurons. Here we are trying to look into neurotrophic factor-based gene therapies which can give a sustained local expression of GDNF, aims to support the dopamine neuron or survival function and potentially slow down the neurodegeneration. There's an early phase encouraging safety focus but still not proven in disease modifying therapies. Then the famous cell replacement therapies are being going on for last 30 plus years. Some of them are quite enthusiastic of recent trials which are going on, but they're all promising and we are looking forward for their outcomes, what may come on. Another interesting work which is going on is on the fecal microbiota transplantation. So what is the concept is the gut dysbiosis may influence inflammation, metabolites and alpha-synuclein pathology via the gut-brain axis. Fecal microbiota transplantation attempts a system reset, hence an improvement. Currently, we have equivocal signals, but heterogeneity is high and it needs to be likely shift towards defined consortia, next generation probiotics or postbiotics and biomarker stratified trials than broader fecal transplantations. The most disappointing probably have been works on iron chelation therapy because this has ended up with as being a negative but harmful trials and group had worse Parkinsonism measures versus the placebo therapies. Just to summarize here, there have been various targets which is based upon either to target proteinopathies, genetic pathways, neuroinflammation or restorational by repairs. Lot of things are happening. Some of them are promising, some of them are in the phases. We are just waiting for possible an eureka moment. There have been definitely been some hard lessons, which can be in relation to the iron chelation, some anti-synuclein programs, and several repurposing trials being ending as negative bar neutral. Definitely, as of today, I can definitely promise that we have moved from symptomatic therapy to biology targeted stratification. But definitive disease modification therapy remains unproven. So what does that mean? Does that mean that do we going to have a new child? The new child, which is anupalabdhi, means according to Indian Mimamsa, is absence of cure cannot be taken as possible impossibility. Yes, we are at the junction for a cure for Parkinson's disease, but how soon? Which pathway? Probably is difficult to tell. Is it we are going to get the pathway of neuroprotection to avoid the further degeneration of neurons, or something we get as an early biomarker which can be arrested, or we have a concept which comes as cell replacement, which will replace the lost dopamine cells in a perfect harmonical way, or we can have a functional remission. Can we get this cure for Parkinson's disease? Yes, this is what we are all looking for. Absence of cure is not a evidence of impossibility. It is evidence of incomplete understanding. And we are at this junction of evolution of management of Parkinson's disease. Perhaps what I can tell is cure is a scientific question, not a philosophical impossibility, what I can see here. As you can see, the evolution of uh, the Benjamin Button from an old child who is almost dying to becoming a young child as it goes down, we have evolved here from the abandoned child concept to the old treatment periods. We have seen the miracle years, we have seen the paradox age, we have accumulated a lot of knowledge. We are now working on our intuitions. Possibly we are only left with our future child here, where we are not too far away. It's question of not when, but when we are going to have this. Like what has happened, the best examples what I can remember is the evolution of treatments for HIV. Probably in early 80s when HIV was found, it was inevitable death. It was no treatment options were available. Within 10, 20, 30 years, HIV has evolved from an inevitable death, the abandoned child, to becoming a disease which has good treatments. People don't even talk about it in a big way as if nothing is there. This has happened in our lifetime, and Parkinson's disease is just not far away. We are at the cusp, at least the current generation probably are at the cusp to see the future child, the Anupalabdhi, what we are talking about, can be seen. Perhaps Parkinson is not a disease aging towards inevitability, but a child in a reverse waiting for us to understand it differently. Thank you. Thanks a lot for all this opportunity to talk to this august audience. Any questions, I'll be able to take it at the end of these sessions. Thank you. Thanks a lot. I'm very thankful for the Parkinson's Research Alliance of India, the Keep Moving Foundation, Global Genetics Parkinson's Program, the Michael J. Fox Foundation, who have been supporting us for our works across India, what we are doing for various projects in relation to Parkinson's disease. Thank you once again.